Chapter 1. Introduction. Beauty, social recognition, and cultural pressure. The concept of beauty is universal and ancient, with cosmetic use dating back to ancient Egyptians. Beauty refers to pleasing properties characterized by balance, proportion, symmetry, complexity, contrast, and clarity. Evolutionary psychology links physical attractiveness to Darwinian survival and social recognition, while social psychology views it as a broader psychosocial construct encompassing intelligence, social competence, friendliness, likability, and leadership, as well as inner qualities like character and values, requiring evaluation of both outer features and inner qualities. The psychosocial perspective argues that beauty, especially a stereotype for women, is essential for social recognition and is associated with several positive attributes such as high intelligence, social competence, friendliness, likability, and leadership skills. This association between appearance and perceived personal quality is not incidental or marginal. It is pervasive, cross-cultural, and deeply embedded in social structures. The standards of beauty are set by culture and change over time. Historical shifts from the trend of fuller-figured women in the 15th to 18th centuries to the narrow-waisted ideal of the 19th century, to the contemporary international standards of lighter skin, narrow waist, prominent cheekbones, and fuller lips for women, and physical strength and higher socioeconomic status for men, demonstrate that beauty is fundamentally a social construction that changes in response to cultural forces. What does not change, however, is the pressure to conform to whatever beauty standard prevails in a given cultural moment. Media plays a particularly powerful role in constructing and enforcing these standards. Media has a proven role in changing perceptions of beauty, inducing age-related fear in the public, promoting anti-aging products with the idea that beauty is strongly associated with youth, and presenting females as sex objects by unrealistically editing pictures and videos through software. Social media is more interactive than traditional media in developing beauty standards, and celebrity idealization is one of the strongest reasons individuals seek cosmetic surgery. These media forces do not merely reflect cultural beauty standards, they actively create and intensify the fear of failing to meet them. Attractive people, in almost all cultures, are taken positively, while the less attractive ones are ostracized. This social reality generates enormous pressure on individuals to conform to culturally determined beauty standards, and it is within this pressure that the psychological roots of cosmetic behavior must be sought. Society affiliates several positive attributes with the physically attractive, considering them more positive, more helpful, more intelligent, more friendly, less criminal, better students, more likely to be employed, and hired on higher wages. Given such pervasive social rewards attached to attractiveness, the fear of being or becoming unattractive becomes a clinically meaningful psychological condition. The psychological consequences of not meeting these standards are severe and well documented. People considered unattractive in society are regarded as having negative personality traits. Considering oneself physically unattractive or perceiving one's body negatively has been associated with several adverse effects such as frequent dieting, bulimic symptoms and dietary restraint, weight gain, poorer psychological well-being, depression, and lower self-esteem. Conversely, greater satisfaction with one's body and physical appearance has positive associations with healthy behaviors, higher self-esteem, sexual satisfaction, and overall psychological well-being. These consequences collectively constitute the motivational architecture within which cosmetic behavior must be understood. The positive and negative use of cosmetics and cosmetic dermatological treatments. Cosmetic dermatology is an emerging and rapidly expanding subfield of medical science that involves both surgical and non-surgical procedures to address problems of physical appearance. These procedures include skin disease treatment, anti-aging processes, rejuvenation procedures, breast augmentation and reduction, liposuction, abdominoplasty, laser hair removal, hyaluronic acid injections, laser skin resurfacing, genital cosmetic surgery, body contouring, vascularized composite allotransplantation. Several new fields have formed within this expanding domain. Dermacosmetics involves products made of biomaterial nanoparticles through nanotechnology, including niacinamide, salicylic acid, and nicotinamide, that are topically applied to treat skin and scalp conditions. Cosmeceuticals is a propagating field that integrates cosmetics and pharmaceuticals, involving products used to rejuvenate the skin, enhance its health, and protect it from disease. Minimally invasive cosmetic procedures, MICPs, including Botox, chemical peels, botulinum toxin, and soft tissue fillers, are increasingly preferred by patients and adopted by practitioners. Cosmetic dermatological treatments serve several legitimate and beneficial purposes. Dermatological procedures address genuine medical conditions such as acne, rosacea, hyperpigmentation, scarring, and skin diseases. The treatment of these conditions produces both physical and psychological benefits. The prescription of appropriate skincare products by practitioners leaves a strong positive influence on patient well-being and satisfaction. Aesthetic surgery, when appropriately indicated, is intended to improve psychosocial and psychological well-being and does help in restoring self-esteem, addressing dissatisfactory body image, and managing psychological issues associated with genuine physical conditions. Reconstructive procedures, including vascularized composite allotransplantation for face and hand transplantation after accidents or trauma, serve essential restorative medical functions that are entirely distinct from cosmetic use, driven by psychological distress about normal appearance. Everyday cosmetic use, such as makeup, grooming, personal style, is similarly a healthy and legitimate aspect of self-expression for many individuals. When cosmetics are used as a means of authentic self-expression, creative personal presentation, and enjoyment of one's appearance rather than as a compulsive defense against the fear of unattractiveness, their use is psychologically healthy and does not constitute charismaphobia, the persistent, excessive, and clinically significant fear of being or becoming unattractiveness. The clinical distinction between healthy cosmetic use and charismaphobia-driven cosmetic use is not about the type or quantity of cosmetic products or procedures used, but about the psychological motivation driving their use. Specifically, whether that motivation is grounded in authentic self-expression and enjoyment, or in the fear-based avoidance of charismaphobic anxiety. Furthermore, there are population groups for whom cosmetic treatments carry specific and significant psychological benefits that are medically justified. Individuals who have experienced disfiguring accidents, burns, or congenital conditions may derive substantial psychological benefit from cosmetic procedures that restore a more typical appearance. Transgender individuals seeking gender-affirming cosmetic procedures have medically and psychologically documented needs that are served by cosmetic dermatological intervention. Cancer survivors who have experienced treatment-related changes to their appearance may benefit significantly from cosmetic restoration procedures. In all of these cases, cosmetic treatment addresses a genuine and externally caused disruption to appearance and self-image rather than a fear-based psychological condition about normal appearance. The problematic use of cosmetics and cosmetic treatments occurs when cosmetic behavior is driven not by genuine medical need or healthy self-expression, but by the psychological condition of charismaphobia, the persistent, excessive, and clinically significant fear of unattractiveness. This problematic use is characterized by several features that distinguish it from legitimate cosmetic use. There are several psychological characteristics and disorders associated with cosmetic treatment seeking that indicate psychological rather than medical need. These include body image disturbance, personality disorders, sociocultural pressure, history of teasing, and psychological distress. Careful assessment of the patient must be done before any cosmetic procedures to determine whether the patient's cosmetic treatment seeking is medically appropriate or psychologically driven. Practitioners must be aware that pathological preoccupation with minimal or non-existent appearance flaws, as in body dysmorphic disorder and charismaphobia, represents a contraindication for cosmetic procedures rather than an indication for them. Cosmetic dermatologists must be able to distinguish between mentally healthy and mentally unwell patients. They must determine whether cosmetic surgery would be appropriate for a given patient or whether psychological intervention is the more clinically appropriate first response. Patients with psychological conditions, such as body dysmorphic disorder, BDD, have no change in their thinking process or symptoms even after the surgery, whereas patients without any significant psychological conditions report improvement following cosmetic procedures. This finding has a direct clinical implication that extends beyond BDD to charismaphobia. Cosmetic procedures performed on charismaphobic clients who are seeking to resolve their fear of unattractiveness through physical intervention do not resolve the underlying psychological condition and therefore cannot provide lasting benefit. The charismaphobic anxiety returns, often intensified, after the cosmetic effect diminishes, because the intervention has addressed the behavioral expression of charismaphobia rather than the underlying fear. The problematic use of cosmetics and cosmetic treatments is further demonstrated by several clinical findings in the literature. Cosmetic tourism, the practice of traveling to cheaper countries for cosmetic surgery, is increasing the risk factors and post-operative complications because of the reduced quality of products and procedures, further normalizing the trend of aesthetic surgeries while simultaneously increasing medical risk. This phenomenon reflects the escalating treatment zone behavior of charismaphobic individuals who are willing to accept substantial medical risk in pursuit of cosmetic solutions to a fundamentally psychological problem. The malpractice dimension of problematic cosmetic treatment must also be acknowledged. There are practitioners who have become unethical in pursuit of monetary gains. They take commissions from product companies, recommend unnecessary procedures, and bill beyond what the patient's condition requires. The private clinic environment provides insufficient regulatory oversight for these practices. Patients are frequently not fully informed about the complications that might occur during or after cosmetic procedures. This is a failure of informed consent that is particularly ethically troubling when the patient's decision to seek the procedure is driven by charismaphobic anxiety rather than informed medical judgment. Globally, 3 to 16% of people are adversely affected by medical interventions, and dermatological procedures carry their own range of adverse effects, including postoperative burns, hyperpigmentation, hypopigmentation, erythema, allergy, scarring, and blistering. These medical risks are acceptable when procedures are medically indicated. However, they are not acceptable when they are incurred in the service of addressing a psychological condition that would be more appropriately and safely treated through psychotherapy. The unsuitable candidates for cosmetic procedures, those whose treatment seeking is driven by psychological conditions rather than genuine medical need, include patients with suicidal ideation, self-mutilation, depression, psychological instability, and specifically charismaphobia. All ethical concerns and consequences of any cosmetic procedure should be discussed with patients beforehand. And practitioners should understand that recommending cosmetic procedures to psychologically distressed patients whose distress is unlikely to be resolved by cosmetic intervention constitutes a clinical and ethical failure regardless of the technical quality of the procedure performed. Psychodermatology, the cosmetic industry as a biopsychosocial phenomenon. The global cosmetic and beauty industry represents one of the most economically powerful and psychologically consequential phenomena of contemporary life. Individuals across cultures, age groups, income levels, and genders invest substantially in cosmetic products, procedures, and services, ranging from everyday makeup and grooming to laser skin resurfacing, hyaluronic acid injections, liposuction, rhinoplasty, and cosmetic surgery. The motivations underlying this investment, however, have remained theoretically underexplored. Why do people seek cosmetic treatment? What psychological condition drives the escalating, compulsive, and sometimes medically unjustified cosmetic behaviors observed in clinical settings? And what therapeutic intervention can most effectively address the root psychological cause of cosmetic dependency? The field of psychodermatology has begun to address this gap. The relationship between mind and skin is one of the oldest and most clinically significant connections in medical science. Both the skin and the central nervous system share a common embryological origin. Both develop from the same ectodermal layer in fetal development, providing a biological basis for the profound and bidirectional relationship between dermatological conditions and psychological states that clinicians have observed across centuries of medical practice. Contemporary science has formalized this relationship through the emergence of psychodermatology. Psychodermatology is a field that represents the amalgamation of neurology, mind, and skin, and that has rapidly established itself as one of the most clinically important interdisciplinary developments in modern medicine. The evidence for the bidirectional relationship between psychological conditions and dermatological problems is extensive and compelling. Psychological distress does not merely accompany skin conditions as an incidental comorbidity. It actively generates, sustains, and exacerbates them through neurobiological pathways involving the hypothalamic pituitary adrenal axis, the autonomic nervous system, and the skin's own neuroimmunological system. Stress hormones, particularly cortisol, directly impair skin barrier function, increase inflammatory responses, and exacerbate conditions including psoriasis, eczema, acne, and rosacea. Conversely, visible skin conditions generate significant psychological distress, such as shame, social anxiety, depression, and body image disturbance. That in turn sustains and intensifies the dermatological condition through the same neurobiological pathways. This bidirectional relationship creates self-reinforcing cycles of psychological and dermatological distress that neither purely medical nor purely psychological intervention can fully address in isolation. The relationship between dermatology and psychopathology has been documented across a broad range of conditions. Physical unattractiveness and the perception of a negative body image have been recognized as important public health concerns worldwide. Cultures associate pleasing appearances with positive human qualities, while unattractive appearances are associated with negative personality traits. These stereotypical perceptions generate psychological harm by lowering self-esteem and contributing to health-related hazards, including depression and eating disorders. A positive body image results in positive behavioral outcomes, while a negative body image results in destructive habits. Considering oneself physically unattractive has been associated with several adverse effects, including frequent dieting, bulimic symptoms and dietary restraint, weight gain, poorer psychological well-being, depression, and lower self-esteem. Greater satisfaction with one's body and physical appearance, by contrast, has positive associations with healthy behaviors, higher self-esteem, sexual satisfaction, and overall psychological well-being. Several specific disorders of the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, have been formally identified as associated with dermatological conditions. Obsessive-compulsive disorder, OCD, trichotillomania, hair-pulling disorder, and skin-picking disorder, excoriation disorder, represent three conditions in which the skin is the direct site of psychopathological behavior. There is a high prevalence of psychiatric disorder in dermatology patients generally, and if psychiatric disorder is not treated, it adversely affects dermatological treatment outcomes. Training and greater psychological awareness can substantially improve the outcomes of patients with psychocutaneous disorders. Psychodermatology has established that there is a link between psychiatric symptoms and skin problems. Many skin problems cause psychiatric symptoms, and many psychiatric conditions manifest through skin-directed behaviors. Several psychiatric disorders have been identified as associated with skin conditions, of which two are idiopathic. Psychodermatology is particularly suitable for treating depression and anxiety that arise because of skin conditions, and for addressing the psychological dimensions of appearance-related concerns that drive dermatological treatment seeking. The treatment of psychodermatological disorders in a single integrated setting, combining dermatological and psychological expertise, is both clinically superior and more cost-effective than treating the dermatological and psychological dimensions separately. The field's emergence reflects a fundamental clinical insight that the skin is not merely a biological organ to be treated with pharmacological and procedural interventions, but a psychosocial surface, a site where cultural expectations, personal anxieties, social comparisons, and identity struggles are expressed, managed, and sometimes pathologically inscribed. Addressing skin-related distress without addressing the psychological conditions that generate and sustain it is clinically incomplete. Psychodermatology provides the theoretical and practical framework for integrated treatment that addresses both dimensions simultaneously. Charismatherapy, as introduced here, represents the most specific and clinically targeted contribution to this integrated framework. Charismaphobia, a brief introduction. Charismaphobia was coined by the author as a new mental condition that involves all relevant symptoms prevalent in patients of cosmetic dermatology. It is defined simply as the fear of unattractiveness. It can be present in both men and women and further includes two conditions: the fear of being unattractive and the fear of becoming unattractive after being regarded as attractive earlier in life. The criterion and judgment for attractiveness in both conditions are obtained through social recognition, making charismaphobia inherently a psychosocial, not merely individual, phenomenon. The clinical symptoms of charismaphobia include the excessive and persistent presence of having a strong desire to be socially appreciated for physical attractiveness and bodily features alone, having a strong desire to dominate others through physical attractiveness alone, having a strong desire to look significantly younger than the chronological age, having a strong belief to be comparatively better than others based on physical attractiveness and bodily features alone, spending unjustified time on the internet to follow the latest fashion trends, being extremely sensitive and selective in dressing, having anxious thoughts about being regarded as unattractive by others, and taking medically unjustified measures to get or stay attractive. Critically, the presence of the last two symptoms, anxious thoughts about being seen as unattractive, and taking medically unjustified measures to stay attractive, is mandatory for a diagnosis of charismaphobia. These two symptoms together constitute the charismaphobic anxiety that is the central engine of the condition. Furthermore, these symptoms must be persistent, present for at least 6 months, to qualify as charismaphobia. This temporal criterion distinguishes charismaphobia from transient concerns about appearance and situates it as a clinically meaningful and enduring psychological condition. The charismaphobia scale, developed and validated by the author, identified 4 validated factors: self-exhibition, narcissistic trends, media consumption, and charismaphobic anxiety. The scale demonstrated excellent reliability and significant convergent validity with generalized anxiety disorder, obsessive-compulsive disorder, and narcissistic personality disorder. These psychometric properties, discussed in detail in Chapter 3, establish charismaphobia as a measurable, reliable, and empirically grounded psychological construct. The insufficiency of existing frameworks in explaining cosmetic use and appearance management. Terror management theory, TMT, derived from Becker's existential philosophy and developed by Greenberg, Piszczynski, and Solomon, 1986, proposes that much of human behavior is motivated by the management of existential anxiety about mortality. Within this framework, physical beauty and youth have been interpreted as symbolic defenses against death awareness. By appearing young and attractive, individuals symbolically distance themselves from the bodily deterioration associated with aging and death. While TMT offers a philosophically rich account of anti-aging cosmetic behavior, it is insufficient as a comprehensive framework for cosmetic use. It does not account for the cultural specificity of beauty standards, cannot explain why cosmetic behavior targets culturally variable attractiveness ideals rather than universal mortality symbols, and does not provide the clinical diagnostic framework needed for therapeutic application. The anxiety subscale of charismaphobia scale does include items referencing fear of aging and its consequences for attractiveness, which aligns with TMT's emphasis on mortality salience, but charismaphobia extends beyond existential anxiety to identify the social recognition system as the proximal driver of cosmetic behavior. Objectification theory, developed by Fredrickson and Roberts, 1997, proposes that in cultures that sexually objectify the female body, women internalize an observer's perspective on their physical selves. leading to habitual self-monitoring and a cascade of negative psychological consequences including body shame, appearance anxiety, depression, and eating disorders. This framework captures important dimensions of the social pressure dynamics involved in charismaphobia, particularly the role of social recognition and the external evaluative gaze. The criterion and judgment for attractiveness in charismaphobia are obtained through social recognition, directly paralleling the objectification framework's emphasis on the external gaze. However, objectification theory is primarily gendered and focused on women, while charismaphobia can be present in both men and women. It also does not provide a clinical diagnostic framework or validated measurement instrument, and does not account for the full range of cosmetic behaviors, including surgery-seeking, cosmetic dependency, and escalating cosmetic procedure patterns that charismaphobia addresses. Social comparison theory, originally proposed by Festinger, 1954, argues that individuals evaluate their opinions and abilities by comparing themselves with others. Applied to beauty and cosmetic behavior, upward social comparison, comparing oneself with individuals perceived as more attractive, drives body dissatisfaction and cosmetic use. Media plays a critical role in providing comparison targets. Media has a proven role in changing perceptions of beauty, promoting anti-aging products, and presenting females as sex objects by unrealistically editing pictures and videos. Social comparison dynamics are clearly implicated in charismaphobia, particularly through the media consumption dimension, characterized by watching beauty advertisements, subscribing to beauty channels and blogs, and searching for beauty products online. However, social comparison theory explains a mechanism without explaining why some individuals develop clinically significant and persistent beauty anxiety, while others exposed to the same comparison stimuli do not. Charismaphobia theory addresses this gap by positing the fear of unattractiveness as the individual vulnerability that determines the intensity of response to social comparison stimuli. Evolutionary psychology has offered an influential account of beauty-related behavior grounded in natural and sexual selection. From this perspective, physical attractiveness serves as a reliable signal of genetic fitness, reproductive health, and immunocompetence, and the universal preference for certain physical features, bilateral symmetry, clear skin, appropriate waist-to-hip ratio, and indicators of youth, reflects evolved psychological mechanisms for mate selection. Cosmetic behavior, in this framework, is understood as an evolved strategy for enhancing perceived mate value by mimicking or amplifying the cues of genetic fitness. The evolutionary perspective captures important truths about the cross-cultural and apparently universal dimensions of physical attractiveness preferences. Studies have revealed that men seek beauty in women and women seek wealth from men, and the role of physical attractiveness is considered extremely important in dating, marrying, and remaining satisfied in intimate relationships. The Darwinian survival of the fittest principle has been associated with physical attraction as the strongest means of social recognition, providing an evolutionary basis for the social reward of attractiveness that generates charismaphobic anxiety. The evolutionary perspective captures important cross-cultural dimensions of attractiveness preferences, but cannot account for cultural specificity and historical variability of beauty standards. Nor can it explain the clinical pathology of charismaphobia, the obsessional quality, comorbid anxiety, and impairment of functioning that characterize the condition at clinical levels. The review above reveals a consistent pattern. Each existing theoretical framework captures important dimensions of cosmetic behavior, but none provides a comprehensive, clinically grounded, psychosocially complete account of why people use cosmetics. TMT explains existential motivation, but not social mechanisms. Objectification theory explains gendered social pressure, but not clinical pathology. Social comparison theory explains a key cognitive mechanism, but not individual vulnerability or clinical comorbidity. Evolutionary psychology explains cross-cultural attractiveness preferences, but not cultural specificity or psychopathology. Charismaphobia, as an established clinical construct with a validated measurement instrument, addresses these collective gaps by providing a unified explanatory and therapeutic foundation for understanding and addressing appearance management and cosmetic use. It incorporates the social pressure dynamics of objectification theory, the comparison mechanisms of social comparison theory, the existential dimensions of TMT, and the cross-cultural attractiveness insights of evolutionary psychology, while going beyond each to offer a clinical diagnosis, a validated scale, and a theoretical model of cosmetic behavior. Charismatherapy, a brief introduction. Despite the well-documented psychological burden of appearance-related distress among cosmetic dermatology clients, and despite the growing recognition within psychodermatology that the psychological conditions driving cosmetic use require psychological intervention, no named psychotherapy has previously been proposed to specifically address charismaphobia as the primary determinant of appearance management and cosmetic use. This book introduces charismatherapy, a charismaphobia-based individual psychotherapy designed to address the fear of unattractiveness and reduce cosmetic dependency through perceptual reframing, unique feature identification, and holistic attraction development. Charismatherapy completes a clinical trilogy that began with the establishment of charismaphobia as a named mental condition, a specific anxiety subtype characterized by the persistent and excessive fear of unattractiveness, and continued with the development and validation of the charismaphobia scale as the measurement instrument for assessing its 4 empirically validated dimensions of self-exhibition, narcissistic trends, media consumption, and charismaphobic anxiety. Where charismaphobia identifies the condition and the charismaphobia scale measures it, charismatherapy treats it. This trilogy follows the logical scientific sequence that characterizes landmark contributions to clinical psychology. Identify the condition, measure the condition, treat the condition. Charismatherapy is grounded in a foundational clinical philosophy that distinguishes it from all prior approaches to appearance-related psychological distress. This philosophy is captured in the author's therapeutic aphorism: "Beauty is to feel beautiful." This aphorism encapsulates the core premise of charismatherapy: that beauty is not an objective external standard to be achieved through cosmetics or surgery, but a subjective internal experience, a matter of perception rather than physical conformity. If beauty is fundamentally a matter of perception, then beauty can be cultivated therapeutically without any change to physical appearance. This insight constitutes the most clinically liberating dimension of charismatherapy. It removes the cosmetic industry's entire premise from the client's psychological architecture and replaces it with a self-generated, sustainable, and authentic sense of beauty and attraction. Central to charismatherapy's philosophical architecture is a clinically original and therapeutically significant distinction between the concepts of beauty and attraction. Beauty and handsomeness, as culturally defined standards, are age-dependent, culturally variable, and exclusionary. Not every person can meet the specific beauty standards prescribed by their culture at every stage of their life, and those who cannot are placed at chronic psychological risk of charismaphobic anxiety. Attraction, by contrast, is age-independent. A person can be genuinely attractive at any age, culturally inclusive, because it is grounded in the whole person rather than in specific physical features, and universally achievable, because every person, regardless of skin tone, body shape, age, or cultural background, possesses the capacity for genuine attraction. The therapeutic shift from aspiring to be beautiful to aspiring to be attractive is not a lowering of the client's aspirational standard, but an elevation of it, replacing a narrow, cosmetically dependent, and externally imposed standard with a broad, internally cultivated, and universally accessible one. Charismatherapy, discussed in detail in Chapter 4, is delivered as a standalone 5-hour individual session, reflecting its focus on the individual's unique appearance-related profile of personal strengths, psychological vulnerabilities, and specific charismaphobic patterns. It is applicable to all individuals experiencing charismaphobia or engaged in problematic cosmetic use, regardless of gender, age, cultural background, or skin tone, and can be delivered at different levels of clinical depth by clinical psychologists, trained counselors, cosmetic dermatologists with psychological training, and beauticians with appropriate training. The distinction between legitimate and problematic cosmetic use establishes the clinical boundaries of charismatherapy with important precision. Charismatherapy is explicitly not designed for individuals with genuine dermatological conditions requiring medical treatment. These individuals should seek and receive appropriate medical care from qualified cosmetic dermatologists and dermatological practitioners. Similarly, charismatherapy is not designed for individuals whose everyday cosmetic use is grounded in healthy self-expression and authentic personal presentation, rather than charismaphobic anxiety. Charismatherapy is specifically designed for individuals whose primary problem is psychological, whose cosmetic use, treatment seeking, and appearance management behaviors are driven by the clinically significant fear of unattractiveness that constitutes charismaphobia, and for whom cosmetic treatments are not medically necessary, but are being sought as psychological solutions to a fundamentally psychological condition. These are the individuals whose charismaphobic prevalence was documented among cosmetic dermatology and beautician clients, and whose psychological conditions were recognized but not adequately addressed by the cosmetic professionals serving them. The clinical pathway implied by this distinction is clear and important. When an individual presents to a cosmetic dermatologist or beautician with appearance-related concerns, the first clinical question is whether those concerns have a genuine medical basis requiring dermatological treatment. If yes, if there is a skin condition, a medical disfigurement, or another genuine dermatological need, the individual should receive appropriate medical treatment. If no, if the individual's appearance-related concerns are driven by charismaphobic anxiety about normal appearance features rather than by a genuine medical condition, the individual should be referred for charismatherapy rather than offered cosmetic treatment that cannot address the underlying psychological condition and may in fact deepen their cosmetic dependency and reinforce their charismaphobic anxiety. This clinical pathway does not exclude the possibility of combined intervention. Some individuals may have both genuine dermatological needs and comorbid charismaphobia, requiring both medical treatment and charismatherapy simultaneously. In these cases, coordinated care between the cosmetic dermatologist and the charismatherapist is the clinically optimal approach, ensuring that medical needs are addressed medically while the psychological condition is addressed psychotherapeutically, and that the two interventions reinforce rather than undermine each other. This book's contribution, i.e. charismatherapy, therefore occupies a precisely defined and clinically essential space in the treatment landscape. It is the psychotherapeutic response to the psychological condition that drives problematic cosmetic use, complementing rather than competing with legitimate medical cosmetic dermatology and filling the gap that medical treatment cannot address. Chapter Summary. The preceding sections have established the foundational clinical and theoretical context within which charismatherapy is situated. Beauty is not a trivial or purely aesthetic concern. It is a psychosocial reality with measurable consequences for social recognition, professional outcomes, intimate relationships, and psychological well-being across cultures and throughout history. The cosmetic industry that has grown around this reality is economically enormous and psychologically consequential, and the field of psychodermatology has begun to document the clinical significance of the relationship between appearance-related distress and dermatological and psychological outcomes. Within this landscape, charismaphobia, the persistent, excessive, and clinically significant fear of unattractiveness, has been identified, named, and clinically defined as the primary psychosocial condition that drives appearance management and cosmetic use beyond the boundaries of healthy self-expression and into the territory of compulsive, escalating, and medically unjustified behavior. The distinction between legitimate cosmetic use and charismaphobia-driven cosmetic use, grounded in the psychological motivation behind the behavior rather than in the type or quantity of products or procedures used, is the foundational clinical distinction upon which all subsequent chapters build. Chapter 2 develops the multi-theoretical foundations that explain charismaphobia across the full range of psychological schools, establishing the comprehensive explanatory architecture that positions charismaphobia as not merely a clinical observation, but a theoretically grounded and scientifically coherent psychological construct.